Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody, and welcome to this grand round. It's my pleasure to introduce Dr. Abdulaziz AlHadlaq. Dr. Abdulaziz AlHadlaq is assistant professor in Al Qasim University, and currently he is a vitro-retina consultant in Security Forces Hospital. Dr. Abdulaziz, he had several publications in local and international journals, and he's going to talk today about refractory diabetic macular edema. So please, Dr. Abdulaziz, go ahead. Thank you.
Thank you, Dr. Mazen. Assalamu alaikum wa rahmatullahi wa barakatuh. Masa al-khair jami'an. It's my pleasure, actually. I'm very happy to join KKish back, even if it is virtual, and inshallah ta'ala, this thing will be solved soon. My talk today will be about refractory diabetic macular edema. As all of you know, the diabetic macular edema is a main cause of moderate visual loss in diabetic patients. As projected in the future, that in 2045, the estimated worldwide prevalence of diabetic patients will be around 700 million people. And the lifelong risk in developing diabetic macular edema among diabetic patients ranging from 10 to 30%. And depend on the diabetic medication that they are using. If there is an improvement in diabetic medication, inshallah ta'ala will be soon that this disease will be controlled. By definition, in general, diabetic macular edema is defined as any retinal thickening in the macula associated with diabetes and accumulation of intraretinal fluid primarily in the inner as well as in the outer bixiform layer. And it is believed as a result of hyperpermeability of the retinal vasculature. And if this disease process, the diabetic macular edema, was not controlled very well with conventional treatment, at that time, this will be labeled as refractory type. So refractory, labeling the patient as refractory type, it will depend on the era that we are living in. So for example, before 10 years, if the patient did not improve on laser, they will label him as refractory type. And now in era of injection with anti-VEGF, if the patient will not improve on anti-VEGF, this will be labeled as refractory type. And the future, we don't know what will be the definition of refractory type of diabetic macular edema. In general, pathogenesis of diabetic edema in general, it is a metabolic changes and inflammatory reactions in diabetic patients that can lead to loss of endothelial tight junctions. A lot of biochemical changes that is happening in the retinal tissue, secondary to abnormal and overexpression and overproduction of a lot of chemokines and cytokines. And one of them that we know about it is the vascular endothelial growth factor. But we have a lot of growth factors that was not targeted by any medication till now. And this is explaining why the high chances of these patients, they will end up with a treatment-resistant cases. So it's not a leakage. It's not only a hyperpermeability of the blood vessels. It's not only the loss of the tight junctions. It's not only the loss of the blood-retinal barrier. It's a leakage versus inflammation. And secondary to that, it results in structural changes. And we know during vitrectomy, we know a lot of changes that is present in the posterior hyaloid as well as the internal limiting membrane. And the patient with diabetes, these structure will be abnormal and in comparison to a normal non-diabetic patient during vitrectomy. And this is proven actually with some studies. Conventional treatment nowadays involving before almost 10 years, the macular laser was the gold standard based on the TDRS study. But since 2010 and the era of the development of different anti-VEGF injections, and this became the gold standard treatment. This became the first line treatment, especially for centrally involving diabetic macular edema. And a lot of studies that proven to have the injection is superior to the laser in drying out the macular edema and improving the visual acuity. Intravitreal anti-VEGF injection showed better functional as well as anatomical outcomes than the macular laser photocoagulation. And they need a repeated injections, monthly injection. and different protocol that was assigned and that was designed for these medications. Despite the benefit of anti-VEGF injections, diabetic macular edema still, it can persist in some patients. And some studies shows that almost 40 to 50% of diabetic edema, of diabetic patient in diabetic macular edema, they will have a chronic, persistent, and refractory type, either spongy form or cystic form or a diffuse form or oxidative form. So this is still a very high percentage, even although we have a lot of development in anti-VEGF medications. So the definition of refractory diabetic macular edema, we can defining it as a persistent and chronic, despite receiving the conventional treatment, which is the anti-VEGF plus minus macular laser, either grid laser, either threshold, sub-threshold, or any anti-VEGF injections. But the general agreement, based on a lot of literature that was published, it shows that you have to inject the patient with 3 to 6 consecutive bevacizumab or ranibizumab, followed by aflibercept for 3 consecutive injections. And if the patient, and if the result was suboptimal, that's mean less than 10% improvement based on the baseline, or if it is more than 350 microns of the central macular thickness, this is labeled as the refractory type. And then we came to the treatment option that we have for these patients. Why we are concerning about in refractory type diabetic macular edema? Because this can result in a permanent and persistent and irreversible damage to the photoreceptor. And this can result in vision, and this can result in a permanent loss of vision. Treatment option. A lot of treatment option that was designed for, in general, diabetic macular edema, and in refractory diabetic macular edema, we are combining certain medications and certain treatment options. As a monotherapy, a lot of medication that was used for diabetic macular edema, including anti-VEGF, threshold, sub-threshold laser, steroid injections, and the last resort is the parasplenectomy plus minus ILM peeling. And combining each one of them, either with anti-VEGF alone, or anti-VEGF with steroid, or anti-VEGF with laser, or the vitrectomy plus intravitreal injection, or even after vitrectomy, we are using some medication. So the play role here, we have a limited options. We have anti-VEGF, we have laser, we have steroid, we have surgical options. And the surgical option, we'll go through it. The best treatment strategy for diabetic macular edema, as all of we know that there is no certain best treatment option for these cases. Options including switching between anti-VEGF, steroid, and combining each one of them with each other. And just we are trying to start with the steroid. Steroid, as we know that there is an overexpression and overproduction of abnormal chemokines, and that's why steroid is working very well in these patients. So steroid reduces production and release of all chemical mediators, of all, it's not only the vascular growth factor, into the vitreous. Because of the known side effect of steroid, that's why it is of limited use, including glaucoma, cataract progression, and if there is a migration in the anterior segment. The commercially available components, that is FDA approved, used for intravitreal include Kinalog or triamcinolone acetonide, which is with different concentrations. And this was before actually we used a lot, and we are still using it during surgery. And the recent available one since 6 or 7 years is Ozurdex implant, and was approved in 2014 by the US FDA. And this is injecting 700 micrograms intravitreally, and it lasts around 3 to 6 months, depending on the washout. And followed by, and the last is Alivian, which is a fluocinolone acetonide, injecting 190 microgram. And this is last for almost 1.5 to 2 years. But in general, we'll go through Kinalog injection. The RCR protocol showed that triamcinolone plus laser, and this is why that was included with the laser, because triamcinolone was the first drug available in our hand at that time, before almost 8 to 10 years. And this is what we injected before. And it shows the same result as ranibizumab injection. And after the triamcinolone, the anti-VEGF era came, so that's why Kenalog was not used too much at that time, although it was used with a different technique. It was injected subtenon, it was injected transseptal, with the chances of having central retinal artery occlusion. That's why it wasn't popular at that time. It has a lot of complications. So ranibizumab and anti-VEGF proven to be superior in comparison to triamcinolone plus minus laser. And that's why the Kenalog was not popular. So although a lot of studies also proved that triamcinolone was not working very well for diabetic macular edema, especially refractory type. Ozurdex implant in September 2014, dexamethasone implant was approved by the US FDA for the treatment of diabetic macular edema. And based on the MID study, which is the study that show up the Ozurdex implant and the benefit of it, and the improvement is almost 20 to 30% among patients that does not or did not improve on anti-VEGF. So among the patients that was not improved, almost 40 or 50%. Among the 40%, 20% to 25%, they improved with Ozurdex implant. So still, we are remaining in 50 or 60% that did not improve on Ozurdex implant. And Ozurdex implant is short. It takes around 3 to 6 months maximum. And the recent studies that showed it's safe to be injected second time. Eliviane, it is the latest one and also approved in around 2015. It takes around, the chances of improvement is almost 20%. And the chances of glaucoma in these two medication, Ozurdex or Eliviane, is much less than Kenalog injection. So I think we stopped here in Eliviane. The drawback from the steroid injection were the reported association with elevated pressure, glaucoma, cataract formation, the risk of implant migration in the anterior segment. So it's better to be tailored for certain patients. Parasplenectomy, it was the last resort, but nowadays with some research conducted, it shows a good promising results in cases of refractory diabetic macular edema. So the options, either it was done as vitrectomy alone or vitrectomy plus minus iLM peeling. And the last option, and one of the technique that used in Japan, because the Ozurdex implant was not approved, they use a submacular basis washout because they are washing, because they saw that after vitrectomy, the macular edema is improving, but takes around 1 year to resolve completely. So they kept on struggling the chronicity of this fluid. So they try a basis washout submacular. And one of the last articles that was published, they inject ranibizumab injection submacular, and they find a good result also. We'll go through it. Vitrectomy is the rule of vitrectomy for refractory, tractional or non-tractional diabetic macular edema were reported. And because it wash out all the abnormal factors that is present in the vitreous, leading to more oxygen availability for the retina, reducing the edema. Also, the vitreous samples from diabetic patients showed increased collagen cross-linking, and that's why in the internal limiting membrane, if we are trying to remove the iLM and doing iLM peeling in diabetic patient, it is very strong in comparison to a normal non-diabetic patient. And this is keeping and the thicker the tight and the abnormality in the iLM, is it as a result, is it as a part of the pathology? Is it a barrier from the oxygen that is passing and through the inner retinal tissue? Nobody knows actually, but there were some talk about it. Vitrectomy also removes cellular mediators and growth factors that might be the cause of treatment-resistant diabetic macular edema. One of the studies that was done in Europe, and this is a large multicentric study involving 26 countries sharing in this study, and this is the Europe Vitreoretinal Society Macular Edema study. They proved that parasplenectomy were superior in improving the visual acuity and improving the central macular thickness in 2 years duration. and this is very good. And parasplenectomy with eye-limb peeling alone was used with this study, and resulted in trend line displaying marked visual recovery about 2 to 3 times higher when compared to anti-VEGF alone. And this result was superior to all other treatment groups. The improvement in the visual acuity as well as the macular thickness increases between 12 up to 24 months after surgery. Considering the success of eye-limb removal in regard to explaining the possible mechanism of action, and aside from the favorable changes with the removal of the vitreous peeling results in the removal of the eye-limb barrier as well as local glial proliferation, including astrocytes. The debate after vitrectomy for diffuse diabetic macular edema subtype is that the resolution of macular edema is not always associated with similar functional improvement because it is a last resort, and we are going to vitrectomy if we utilize everything that in our hand. So imagine that we are injecting the patient with 10 or 12 injections, and then at that time with a chronic fluid, and this fluid stays in around more than 1 year, and then we are going for vitrectomy, and the structural changes improved, but of course the functional improvement will not be as superior as if we do it early in the disease process. The other debate is a long course of resolving the macular fluid, which takes around 1 year in 40% of cases. That's why in Japan they use the basis washout. The other debate is the fast washout of anti-VEGF if ever needed after vitrectomy. And that's why some studies, they are injecting Ozurdex implant even after vitrectomy. And this takes a longer time of coverage with the medication. And this graphs show the improvement in the lines. It improved around nine lines. But the course, if you see the blue line is a vitrectomy, and the other options. And the vitrectomy, you see it for the first, the bottom is the month, and the vertical is the improvement in the visual acuity in the lines. So if you see that one, the improvement after vitrectomy plus eye-limb peeling was not so fast. It takes around 6, 8, or 10 months. And this takes around in 40% of cases. So that's why they develop a new technique. They are doing washing basis, washing subretinal or subretinal ranibizumab. We'll pass through it. But the visual acuity, the visual improvement almost double or triple the other options. Studies reported that diabetic macular edema takes a long period of time to improve after vitrectomy. One study showed that only 50% of patients had resolution of macular edema by 3 months, while the other remaining 47% of patients took around 1 year to show improvement. That's why Morizan, this is in Japan, he did basis washout subretinal to overcome this unwanted effect. And they showed that the subretinal basis injection after vitrectomy with eye-limb peeling might be a useful technique for rapidly treating diabetic macular edema. The benefit was shown in the naive cases. Also, they are doing this vitrectomy before they are injecting or utilizing the anti-VEGF. The other study that was done by El-Bahai et al., he did submacular injection of ranibizumab and showed the following result: the preoperative central macular thickness around 500 in the mean, and end up with less than 350 in the mean after just a 1 month duration. And this is a great improvement actually, because in 1 month after vitrectomy you end up with drying the macula. This is very good. It wasn't reported before. So this is the end result of the Europe Vitreoretina Society, and comparing hand to hand, comparing arm to arm between anti-VEGF and parasplenectomy. Although the number of patients that underwent vitrectomy is less by 50% among the patients that's done the anti-VEGF, but the line improvement was much superior in parasplenectomy plus eye-limb peeling in comparison to anti-VEGF. In conclusion, diabetic macular edema remains the main cause of the visual loss in diabetic patients, especially the moderate type. Treating the underlying disease efficiently. So we are taking a patient as a patient, not only we're concentrating in the retina. And sometimes the poor control of diabetes, they need to control it very well. If your patient having HbA1c, for example, by 12 or 13, you don't imagine that you are treating diabetic macular edema and it will stay like that. of course, he will come to you after 2 to 3 months with recurrence of diabetic macular edema. So we have to control diabetes very well, and any coexisting disease, which is very common in these patients. They're having hypertension, anemia, and dyslipidemia, and other chronic also pulmonary cardiovascular disease. We are still in the learning curve in dealing with this chronic disease, and there is not yet agreement about the treatment protocol. And large prospective studies needed to approve or disapprove any treatment options. Thank you so much. It was very fast, but thank you so much.
Thank you so much, Dr. Abdulaziz, for this nice, comprehensive presentation.
حياك الله.
We will take questions.
يعطيك العافية عبد العزيز.
حياك الله.
A few questions, interesting talks always. Few questions regarding the protocol that you are following. Are you going to change the protocol depending on the control of diabetes in the patients? This is the first question.
Okay.
The second question, in the vitrectomy, do you ever try to decrease the period of the interval between the injections?
Okay, regarding the first question, first of all, we have to treat his diabetic case. So first of all, we have to see, is he controlled or no? Usually we are sending him for diabetologist and then controlling very well diabetes, and then we are injecting him with a regular treatment protocol that we are following the anti-VEGF injections. If it is focal leakage, we're going for focal laser, but if it is diffuse type or central involved, we're doing the anti-VEGF. If there is suboptimal result from the baseline less than 10%, so this is not effective, we will shift to another anti-VEGF injection. And if there is no improvement, for example, 3 or 6 injections consecutive, we need to think about either he is suitable for steroid injection or he is suitable for vitrectomy. But you are keeping injecting him once, twice, 3 times with anti-VEGF even, and you're going back to inject him again with anti-VEGF, this is not good.
But you will not wait until the control. You will not send him to the
No. I will treat him. I will inject him. Yes, I will inject him. Meanwhile, we are sending him to a diabetologist, of course.
But if the hemoglobin A1C, for example, is very high, so you expect that you will go like for 6 injection, or you will start the ranibizumab as first line, or the Eylea as a first line. This is what I mean.
Okay. Yeah, even if it is very high, and if you inject now, you will see some result after 1 month. But if the result suboptimal, that's mean regardless, even if the HbA1c was controlled. Some studies proven that HbA1c was controlled and still he has a chronic course of the edema. I mean, this is one of the risk factors. You have to control it, but you don't concentrate on it.
Great. Second question, for the interval between injections and after the vitrectomy.
Because after vitrectomy, the washout is very fast. But even if you inject him and then bring him back after 2 weeks and you see the OCT is not improving, so it's better to shift for, if there is no contraindication, to give a steroid injection, because a lot of studies that proven steroid injection after vitrectomy is better than anti-VEGF.
Okay. For the last question, if you have refractory diabetic macular edema in one eye, and then the patient developed macular edema in the other eye, are you going to consider or expect the refractory situation in that eye, so you will go like for the Ozurdex as a first line?
Of course, no, because it will depend on the concentration of some chemokines. That is, yes, in general, both eyes will be almost the same, but I will not target to go for Ozurdex as a first line in diabetic patient. I will go with, for example, in CRVO or in brush vein occlusion, but I will keep a mind and I will keep a room for anti-VEGF injection from the start. I'll not jump for Ozurdex implant or steroid injection, even with vein occlusion, which is proven to be superior than the anti-VEGF and its chronic course, but will not jump for any steroid injection as a first line of treatment. Unless there is contraindication to anti-VEGF, for example, the patients having cardiovascular disease or recent stroke, for example.
Do you think in refractory situations it depends on on the chronicity of the diabetes and uncontrolled diabetes usually?
This can be, but the other thing, what I find is that if there is extensive exudation in the macula, this is going for a chronic type, usually. If you have exudative, you have lipid maculopathy, this is one of the most difficult cases that to treat with regarding the macular edema. If it is clear fluid, most of the cases they will improve. But if you have exudative type and lipid maculopathy, this is one of the chronic cases. One of the refractory, one of the most difficult cases that to treat actually.
For the delay laser, you'll consider the laser in refractory situation before the other outline like the ozurdex or the triamcinolone, صح?
Nowadays the laser is tailored for focal laser only. Grid laser, actually with a study that finds that after you inject him and you are doing grid laser, the visual acuity after 2 years it will be dropped. So even with a grid laser, you are aiming for diffuse type, you are aiming for ischemic type. If you do fluorescein angiography, there is a room for fluorescein angiography to find that a diffuse type of diabetic macular edema associated with ischemia. And if you do grid laser, there is a room for it, but the visual acuity you will not be optimistic about it.
Thank you.
Welcome.
Thank you, Dr. Saad. There is a question from Dr. Abdullah AlHadlaq. He's asking why we are not using ozurdex commonly on Saudi Arabia. Is it expensive or risk of glaucoma?
It depends on the one who is treating, but in general, as an agreement, first to try with anti-VEGF. If there is no improvement and if there is no contraindication to do ozurdex, there is a room for ozurdex. But we are not jumping it for as a first line treatment in diabetic macular edema. Actually, the ozurdex implant was superior to anti-VEGF in branch vein occlusion or central vein occlusion study, yes. But even though we are not jumping as a first line, but in diabetic macular edema, there is a room for anti-VEGF.
Okay. Okay. Thank you so much, Dr. Abdulaziz, and thank you everybody for participating in this grand round.
Ibrahim al-Mansour, thank you so much.
Thank you.
السلام عليكم.
وعليكم السلام, حياك الله إبراهيم.
شكرا جزيلا دكتور على المحاضرة.
حياك الله, أهلا وسهلا.
2 questions. First question, what is your cutoff of improvement in a patient with cystoid macular edema? I mean, the number in the OCT and the number of thickness, or the visual acuity, or both, so I can continue my treatment.
In general, yeah, okay. This is a question, or do you have another question?
Yeah, I have another one, but we can go with this one first. Okay.
In general, the visual acuity depends not only on the fluid. Sometimes you have fluid of 500 and the visual acuity is 2030. And sometimes you have fluid of 400 and the visual acuity is 2100. This is not there is no relationship between the fluid presence and the visual acuity. The visual acuity depends on the chronicity, depends on the ellipsoid zone, depends on other factors, depend on the ischemia if it is present, the pulse area or whatever. So the visual acuity is not, yes, you are dealing with and you are treating the diabetic macular edema to save and to improve the vision. But actually we are treating the OCT based on our follow-up. So if there is improvement more than 10% or 15% from the baseline that you started with, this is labeled as an improvement, and this is labeled as a good improvement. But the visual acuity, it will improve if his retinal structure is intact. If his retinal structure and the ellipsoid zone and the photoreceptor is not intact, the visual acuity might be not improved. So at that time, if you have fluid of 500 and the visual acuity did not improve, you will stop? Of course, no.
Okay, I got your point. Doctor, the other questions, what is the definition? What is your definition of totally dry macula? Is it normal thickness with normal architecture, or normal thickness regardless of the zone or the architecture?
It's a different, actually based on the literature, they define it by different means. Sometimes there's some literature, they define it as less than 300 microns. Sometimes they define it as a normal of less than 250 microns of the central macula. The normal architecture depends on the chronicity of the fluid. If the fluid disrupts the structure, it will not go back to normal. So drying effect, the general agreement is less than 300. If you reach 300 and less, this is good.
Okay, thank you so much. شكرا جزيلا. الله يسعدك.
Welcome.